Hello everyone, this is Tamanna Naik from the UPMC Jalgaon. Today I am presenting topic antidiarrheal agents before you. In this, we are going to be covering pathophysiology of diarrhea, treatment of diarrhea, rehydration, maintenance of nutrition, drug therapy and sulfasalazine. Let's move to specific treatment. In specific treatment, there is classification of antidiarrheals. In antidiarrheal classification, there are non-antimicrobial antidiarrheal and specific anti-infective agents. In non-antimicrobial antidiarrheals, there comes antimotility agents and anticholinergic agents. In antimotility agents, the drugs are diphenoxylate, loperamide, and codeine. In anticholinergic agents, there are atropine and scopolamine. Now comes specific anti-infective agents. In specific anti-infective agents, there comes antimicrobials and antisecretory agents. In antimicrobials, the drugs are cotrimoxazole, norfloxacin, doxycycline, erythromycin, and metronidazole. Now comes antisecretory agents. In antisecretory agents, the drugs known as sulfasalazine and mesalazine. Let's move to pathophysiology of diarrhea. How does diarrhea happens? Water and electrolytes are absorbed as well as secreted in the intestine. Jejunum is freely permeable to salt and water, which are passively absorbed secondary to nutrients like glucose, amino acids, etc. In the ileum and colon, active Na plus, K plus ATPase mediated salt absorption occurs. Primarily in the mature cells lining the villus tips, water follows isosmotically. In addition, glucose facilitated Na plus absorption takes place in the ileum by sodium glucose cotransporter. One Na plus ion is transported along with each molecule of glucose absorbed. This mechanism remains intact even in severe diarrheas. Bicarbonate is absorbed also by the secretion of hydrogen, similar to that in proximal tubule of kidney, and sodium accompanies it. Potassium is excreted in fecal water by exchange with sodium when non-absorbable solutes are present and in disaccharidase deficiency, which occurs during starvation. The stool water is increased. Inhibition of Na plus K plus ATPase and structural damage to mucosal cell by rotavirus causes diarrhea by reducing absorption. Stimuli enhancing CAMP or CGMP cause net loss of salt and water, both by inhibition sodium chloride absorption in villus cells and by promoting anion secretion. Many bacterial toxins, example cholera toxin, exotoxin, elaborated by enterotoxigenic E. coli, Staph aureus, Salmonella, etc., which enhances secretion. Prostaglandins and intracellular calcium also stimulate the secretory process. Let's move to therapeutic. In therapeutic, measures may be grouped into treatment of fluid depletion, maintenance of nutrition, and drug therapy. Let's move to oral rehydration therapy. Oral rehydration therapy restores and maintains hydration, electrolyte, and pH balance and is life-saving in most cases. Oral rehydration therapy is prepared with NaCl, glucose, and water. In the ileum, glucose enhances absorption of sodium and water follows. Oral rehydration therapy is required when fluid loss is more than 5 to 10% of body weight. IV rehydration is required when fluid loss is more than 10% of body weight. Let's discuss about non-diarrheal uses. Non-diarrheal uses are post-surgical, post-burn, and post-trauma patient maintenance of hydration and nutrition, heat stroke or during change over from intravenous to enteral elimination. Let's move to drug therapy. In drug therapy, antimicrobials in diarrhea. In antimicrobials in diarrhea, there are antimicrobials are of no value in diarrhea due to non-infective cases such as irritable bowel syndrome or pancreatic enzyme deficiency or celiac disease. Then, antimicrobials are useful only in severe disease like traveler's diarrhea caused mostly due to enterotoxigenic E. coli and Campylobacter virus. The drugs used are cotrimoxazole, norfloxacin, doxycycline, reduce the duration of diarrhea and total fluid needed in severe cases. Third is antimicrobials are useful in cholera, amoebiasis, giardiasis, or Campylobacter jejuni. Let's move to probiotics in diarrhea. In probiotics in diarrhea, these are microbial cell preparations, either live cultures or lyophilized powders, that are intended to restore and maintain healthy gut flora or have other health benefits. Diarrheal illness and antibiotic use are associated with alteration in the population, composition, and balance of gut microflora. Recolonization of the gut by non pathogenic, mostly lactic acid forming bacteria and yeast is believed to help restore this balance. Organisms commonly used are Lactobacillus species, Streptococcus faecalis, or Enterococcus species. Let's move to non-specific antidiarrheal drugs. The non-specific antidiarrheal drugs are loperamide, diphenhexylate, and sulfasalazine. Let's talk about loperamide. In loperamide, it inhibits secretion by directly interacting with calmodulin. It is more potent than codeine in causing constipation, and CNS effects are rare. In diphenhexylate, it has more marked antidiarrheal effect. It crosses blood-brain barrier. It has action similar to codeine causing constipation, and the side effect is that it can cause respiratory depression. In sulfasalazine, it inhibits COX, cytokines, PF, and TNF. It reduces frequency of stool. It is used to maintain remission. Sulfapyridine is responsible for rashes, joint pain, fever, and hemolysis. Then let's talk about MCQs. Okay, there are 5 MCQs. First one is, what are some common causes of chronic diarrhea? Options given to you are: first, A is IBS, B is inflammatory bowel disease, C is celiac disease, and D is all of above. Second one is, what is the main treatment of diarrhea? A option is antibiotics, B is anti-inflammatory medication, C is rehydration therapy, and D is surgery. Third, which is an opioid agonist which at high doses can have CNS effects. First one is diphenhexylate, B option is loperamide, C option is sulfasalazine, and D option is resicadotril. Fourth one is, which is anti-secretory drug. The options are A resicadotril, B codeine, C norfloxacin, and D loperamide. Fifth question is, which drug can cause respiratory depression? A option is loperamide, B is diphenhexylate, C is codeine, D is prednisolone. Thank you.